It's a great pleasure to introduce you to Professor Bailey Arruda. She's a veterinarian and a PhD in vet pathology and is currently an associate professor at Iowa State University. And she works as a diagnostic pathologist at the Iowa State Diagnostic Lab. Her interests include infectious diseases of many kinds in swine, and she has worked intensively on pathology and pathogenesis of both old diseases, shall we say, increasingly emerging and re-emerging pathogens, particularly viruses. So, new pestiviruses, sapillovirus, astrovirus, PD, PCV3. So really a huge collection of publications in peer review. And I'm very glad that we have Bailey as a speaker today. She will share us a very interesting presentation, More Mummies Than Expected, Investigation of Viruses Causing Reproductive Failure. Bailey, the floor is yours.
Thank you, Oliver, for that introduction, and thank you all for your attendance and attention. I'm excited to present today. We will be going over 4 topics. So the first one's going to be overarching diagnostic insights, hopefully to get you a diagnosis when you have some disease in your herd. Then delving a little bit more into reproductive failure diagnostic investigation, what samples to take and how to take them. We'll cover specific etiologies primarily focused on PCV3, and then I think there's a single slide concerning PCV2, porcine parvovirus, and PRRS together. We'll then move on to outbreak investigation and causal inference. As alluded to, swine's pretty good at infectious disease. That's what I do on a daily basis, is diagnose infectious disease in swine. So there's a lot of them coming out and being identified using new technology. So going through a little bit in terms of how we can address these new things that keep popping up in our populations. So overarching insights. Well, the world is gray, and at least in the United States, when we are teaching vet students, it's a very black and white world. Vet school dogma: one bug, one disease, moving to Koch's postulates as the gold standard. And I think we really do need to move beyond this in terms of how we practice veterinary medicine and understand disease. We need to look more at ultimate causes and focus a little bit less on the proximate causes. We'll go over the definitions of those in the next few slides. Your details are going to be your determinants to finding answers and a diagnosis. Sample selection, your who you pick, what you submit, and when you pick those pigs are really going to determine if you get an answer or not. When talking about reproductive failure in pigs, you do need to look at individual litters for a case definition. If you walk the barn and you see a litter with a mummy and you grab that mummy and you move 3 crates down and you grab another mummy from that litter where there's a single mummy and you pool those mummies together, probably not the best way to go about getting a diagnosis for reproductive failure. So talking a little bit about proximate versus ultimate causes. So proximate cause is your etiologic diagnosis. So if you submit a case to the diagnostic lab at Iowa State, I'm not entirely sure how diagnostics go over in Europe and or Mexico, but if we get a case, we're going to give you a laboratory diagnosis given to you by a diagnostic pathologist that takes data that you provide from the farm, what we get for PCR and microbial culture, and our pathology, and put it together for a laboratory diagnosis. So for instance, we would give you a diagnosis of porcine parvovirus reproductive failure, but the ultimate cause and the ultimate cause are the risk factors. So maybe you have an ineffective vaccine protocol, or you're deficient in your acclimation of gilts. And really, causality is equivalent to the proximate plus the ultimate causes of disease expression. And this diagram just demonstrates that there's numerous permutations that are commonly required for disease expression. I think that this is easily exemplified by COVID-19, where some people are PCR positive and don't develop any kind of clinical signs, while others are in the ICU and hooked up to ventilators. So all of those things, be it genetics, exposure dose, concurrent diseases, all impact if disease will be expressed. There is no single best test for any agent necessarily. You are likely going to have to reach into the diagnostic toolbox and use multiple modalities to get an accurate diagnosis in swine disease. So anywhere combining PCR with bacterial culture with histologic evaluation, as well as your gross evaluation, is likely going to be your first step in achieving an accurate diagnosis. Detection versus disease, I think this is a really big one, especially in swine medicine. So many common pathogens are endemic in our swine herds. So detection does not necessarily equate to disease. We often have a confirmation bias. So you look for it, you find it, then you blame it. So piglet diarrhea, rotavirus detected by PCR. Well, if you asked me, so I have a rotavirus PCR positive, is it rotavirus enteritis? I would say, what is your CT value? What about bacterial culture results? Did you look for any kind of Delta coronavirus or coronavirus in that sample? History of coccidia, or did you do a fecal float or histopath to look for coccidia? And then do you have consistent histologic lesions within the small intestine? So all of those would be important follow-up questions in terms of the importance of that rotavirus PCR. So this is how we achieve a diagnosis at the diagnostic lab. Our submitters will get a data set one from the farm. So they'll do a clinical and gross examination and hopefully provide that to us. Sometimes we don't get so much information. So for instance, they would say sows are off feed and they have aborted. So additional information to collect on that sow farm would be, is it sows? Or is it primarily gilts? What are you looking for? Parity? Is there any uterine? Is there any vaginal discharge? What stage of gestation? Has there been a change in procedures? What's the time of year? What does your production data look like historically and currently? And what are the sow temperatures? And then based upon all of that information, you can come up with some differentials and also consider where you are within where you are globally, right? So for us, primary differential for sows off feed that have aborted would be PRRS and influenza. You could also look for bacterial causes such as actinobacillus, Aerie, lepto, and brucella. However, those are very uncommon in our swine herd. And then other things that we haven't yet or don't have to deal with on a basis is pseudorabies virus, classical swine fever virus, African swine fever virus, and Japanese encephalitis virus, potentially morbillivirus viruses as well. So seasonal infertility and carbon monoxide would also be differentials in this case. So when you submit samples to the lab, you get data set number 2, which is the lab data set, histopath, unremarkable, PCR. Because serum was submitted from those sows as they were off feed, we have a PRRS reproductive failure. If you're just submitting tissues from fetuses, it's not uncommon to miss that diagnosis because fetuses don't necessarily have to be infected for PRRS to cause an abortion. So key concepts, again, definitions. It's really important to use these definitions because they bring up different differentials based on their definitions. So abortion, anything prior to 112 days of gestation is considered an abortion. Mummified fetuses, which means in utero death with time of dehydration. So that black arrow would be a mummified fetus. The one next to it is what I call a moderate autolysis fetus. Really, it died in utero several days ago, but it hasn't had time to dehydrate. And then a stillborn would be a term fetus, but born dead. So that would be the red arrow. And you can see that these guys, so you can't see, but these guys all came from the same litter. So having that information tells me that probably something was moving along into each of those fetuses while they were in the uterus. So again, not every fetus in a litter is going to be infected. So you need to submit 3 affected litters with 2 to 3 mummified and or stillborn fetuses. So that would be your case definition. So that's why you need to go to the litter to see if they meet that case definition of 2 to 3 mummified and or stillborn fetuses. So then you would submit 4 to 6 fetuses per affected litter. And I know that as pathologists, we commonly complain about freeze artifact, but indeed you can freeze these fetuses. The fetuses that you see on this image were frozen and submitted when they had 3 affected litters. And histopath, while it's a little bit more challenging, it's not impossible to read through the artifact. All right, key concepts. Collect by litter. We pool at molecular for typical etiologies. This saves a bunch of money, at least at the diagnostic laboratory, where we are charging $30 for a PCR. And parvovirus and porcine circovirus usually do not cause abortion. At the diagnostic lab, we will run PCRs for these, but it's really based on the expectation of our submitters and not necessarily that they are a prominent common cause of abortion. Lastly, or not lastly, but number 5, uncommon to see lesions in cases of fetal death. This might be due to multiple factors, including the number of fetuses submitted, the number of fetuses evaluated histologically. So one day I actually got 10 fetuses from a single litter, and I decided to look at all 10 fetuses histologically to see if I could see lesions in what proportion of those fetuses, and actually only one had very mild lesions, and it was a PRRS abortion. So again, histologic lesions aren't commonly seen. It might also be due to the tissues we evaluate, at least at our diagnostic lab. If taken, we take heart and lung, plus or minus kidney and liver. We don't typically look at brain, placenta, or spleen, but you can see in the figure to the right that in a case in which I did take placenta and brain, it was really very important for me to do so because these were the only, within this single stillborn fetus, it was the only lesions that I was able to see. So in the first image, you can see mineralization. It's all that purple stuff in the brain. The arrows are pointing to neurons that are dead, and the circle that's a neuron with an inclusion body within the nucleus. The picture below that is going to be a placenta. There's numerous leukocytes within that placenta. Again, autolysis is pretty severe, so all I can tell you is that those cells shouldn't be there, not necessarily the types of cells that are there. And then we did an RNA scope targeting the virus that was identified using next generation sequencing. And you can see that all of that red is staining for that virus. So the one next to the picture with the arrows is going to be the brain. Down below that is the cerebellum, cerebellum, and then the placenta. You can see it within the placenta. So last of the key concepts, mechanisms of fetal death anywhere from 40 to 70 days is going to result in mummification. So there's infectious, obviously, viral, probably more important than protozoal. And they say bacteria can do it as well. If you look at diseases of swine, they'll say lepto can do it. Again, lepto in our herd is really very, very uncommon. Could also potentially be genetic defects or uterine capacity leading to fetal culling. So if you're looking at a really large litter, you might have that on your differential list. So going a little bit into averages and really looking at individual litters, if you are looking at averages, you likely miss things. So an example, if you look at the herd as a total, you might see a 0.7 mummified fetuses per litter, which probably isn't too bad. If you break it out in terms of sows versus gilts, you can see that there's a little bit of a disparity between those two populations. So again, looking at that 3 or 4 mummies in a litter, I would say that would be a concern to me. And then again, looking at what is normal, a normal number of mummified fetuses in a litter. To me, when we have done case investigations in the field and they use, 3 or more mummified and or stillborns in a litter, it looks like that's a pretty good threshold to be at. So what is an acceptable number of mummified fetuses in a herd? This has varied by the practitioners and the farms that I have talked to. So a point or 0.7 might be too much for some. A 10% mummified fetus rate was enough to get some people to do something. So really, again, it really does vary. So sample types, intact fetuses, as we've covered before, again, those can be frozen by litter and tested by litter. Placenta is always great to get, but not uncommonly submitted. We have sow serum, especially if your sows are sick. Nasal swabs, again, especially if your sows are sick. And then fetal thoracic fluid. So this video demonstrates what we do on the floor to collect fetal thoracic fluid. It's really very easy. You open those guys up, you take a needle and syringe, and you suck up the fluid that's in their thoracic cavity. If shipping is an issue, this really does decrease the cost of shipping. And it's good to sample to run PRRS, PCV2/3, as well as do next generation sequencing on it. Your host depth or your host is diminished. So you're not getting as much pig sample there. So you can increase your depth of sequencing in that sample type. If you guys want more information by system or issue, you can look at this site, and here's the link to that site, and it will provide you porcine quick guides as in terms of what to gather and submit. So it's a pretty good resource. So here's a question for you. How was PCV3 discovered, characterized? Number 1, by PCR. Number 2, PCR and lesions. Number 3, next generation sequencing and lesions. Or number 4, next generation sequencing, lesions, and in situ. Again, how was PCV3 discovered, characterized? All right. So it looks like 21% said PCR, 5% said PCR and lesions, 3% or 42% said next generation sequencing and lesions, and then 4 was NGS, lesions, and in situ. So number 4 is actually correct. If you look at the publications coming out of Minnesota and Kansas/Iowa, both of those used NGS, PCR, as well as in situ to characterize PCV3. And I think that's a good way to move forward in terms of identifying and characterizing pathogens within swine. So talking a little bit briefly about next generation sequencing and the utilities of NGS, there's usually 2 pipelines that you can use for NGS. So a targeted amplicon sequence or whole genome sequencing. These use targeted specific primers. They sequence the genomic region of interest, and like for microbiota, it would be the 16S. Or you could go down the other pipeline and sequencing of all the genetic material. So for instance, in that fetal thoracic fluid, you wouldn't get so much host there. So again, you would increase your sequencing depth. It uses a non-targeted library preparation. You use de novo assembly, and this is the pipeline that we're going to commonly use for what we call a bug hunt. So this is how they identify PCV3. Inclusion into the family Circoviridae, genus Circovirus, typically is not a % similarity for inclusion in a genus family, but rather based on typical taxon features. And to be a different circovirus species, you have to have less than 70% nucleotide similarity over the genome and less than 75% cap similarity. So PCV3 meets both of those requirements. So looking at PCV3 versus PCV2, PCV3 strains are very similar. It's a little bit like comparing a pig to a pig. You can see that on this tree here. While PCV3 is very different from PCV2, again demonstrated by that pig or by that tree there. And it's a little bit like comparing a piglet to a calf. So what we've done in our studies, it does look like PCV2 vaccine does not appear to protect against PCV3 infection. This isn't really a surprise to anybody. In terms of case definition, what's out there for PCV2, this is from Diseases of Swine, and we commonly do not use these definitions for PCV2-RD. So when we're looking at reproductive disease, generally we're just going to call it based on the CT value of a fetal pluck. So we don't need the presence of heart lesions characterized by extensive fibrosis and necrotizing myocarditis to cause a PCV2 reproductive disease failure. So as pathologists, we got together as a group in last January to come up with working pathologic case definitions for PCV3. For reproductive disease, we would have to have stillborns and or mummified fetuses with a PCV3 PCR-CQ value of around 20 to 25 or ISH positive. In these guys, we can see fibrosis and inflammation. The bracket demonstrates fibrosis, so that's all really pale, that really pale area, that's fibrosis. And the asterisk demonstrates inflammatory cells. It's around 18 that you'll start to see these histologic lesions in these fetuses, but they can be segmental. So again, it's going to depend upon how many fetuses were submitted and evaluated, whether or not you're going to be able to catch those lesions. Perinatal disease, weak-born abnormal suckling piglets, inflammation in the brain, heart, and or kidney. Generally speaking, these CQ values are less than 20. Again, you're going to see gliosis, which is the brackets, and inflammation surrounding the vessels, which is the asterisk. Growing pig disease, we define it as lymphohistiocytic or lymphoplasmacytic perivascular inflammation. Generally speaking, this is in multiple organs, so you'll see it in the heart, kidney, plus or minus spleen, and the mesentery. Sometimes you can see it in the brain. So at least at our lab, PCV3 PCR-CQs are in the low 20s for these guys, plus or minus PCV3-ish on those cases. So to give you some background, I'm going to throw up some data from our diagnostic lab. I wanted to give you some background to be able to judge that data by. So the ISU VDL is one of the largest VDLs in the United States. We have about 85,000 cases per year, 75% of which are porcine origin, and 10,000 cases, actually probably more than that, are evaluated by a diagnostic pathologist. Within our section of pathologists, we have 11 diagnostic pathologists, and if you sum all of our experience together in terms of diagnosing swine diseases, it's more than a century's worth. So this is our dashboard for our diagnosticians. It certainly is a work in progress. So I can tell you that in 2018, there are cases that meet that working case definition that are not coded. And there are cases in 2020 that I would not necessarily code because they don't meet the working case definition. But in some, based on this dashboard, there's about 238 diagnoses provided by a diagnostic pathologist. So what are we seeing in these guys when we diagnose reproductive failure? We're seeing fibrosis. Number 1 and 2 are a trichrome. The blue is not supposed to be there. That's fibrosis. And number 3 is the RNA scope-ish. That's brown. That's not supposed to be brown. I'll show you a negative slide so you get an appreciation of what that's supposed to look like. In these mummies and stillborns, we're again detecting millions and billions of copies of genetic material. And we found it in multiple different states, multiple different farms, as well as Mexico. So this is a single litter that was submitted as part of a field investigation. So you can see there's fibrosis and inflammatory cells in picture 1 and 2, and then there's inflammation in the brain, liver, kidney, and heart of the other 2 more normal looking fetuses there. I'm running out of time, so I'm going to kind of speed through all of this. This again is going to be another field investigation, 3 different litters evaluated in the same case. They submitted multiple fetuses per litter, inflammation in multiple organs, fibrosis in the heart, and your PCV3-ish. You can see on the left is really red, in the middle is not so red, and on the right is negative because it was negative for PCV3. All of these were also tested for PRRS, porcine parvovirus 1, 2, PCV1, PCV2, as well as lepto. So point, counterpoint. It has been around for decades. We do not know at what prevalence. Our herd infectious immunity status has and continues to change. We're looking at flow. We have constant flow of genetics into herds, looking at 20%, 25% gilts being introduced into our herds. We had crated gestation. We have large sow farms. All of this is going to combine to limit herd immunity and talking to the point of the human contribution to the ecologic change of these infectious etiologies. There are numerous cases of PDNS and innumerable cases of reproductive failure without detection of known causes over the past decades. And we always deal with endemic agents, and they will cause disease in a subset of individuals due to various factors. So right now, where are we in terms of the importance of PCV3? Well, it's a pathogen of pigs, and it will cause clinical disease in a subset of pigs that are infected. It does not appear to cause enteric disease, primary respiratory disease, or a loss of condition like PCV2. Really, the impact, there's no great answer, probably fetal wastage, and looking at acclimation or potentially vaccine. So porcine parvovirus, porcine circovirus 2, and PRRS, all of these can cause mummified fetuses. If you look back at our cases, it looks like porcine parvovirus and PCV2, the CQ is usually rather low when you're dealing with fetuses. When you look at PRRS, it's not as low in terms of the CQ value. Lesions are fairly consistent despite etiology, so you're going to see myocardial necrosis and inflammation. Moving on to outbreak investigation and the causal inference. This figure really just does demonstrate that after 25 years, there's going to be, and there has been, and there will continue to be introductions of disease into pigs that we will continue to have to battle. So how do we know if it's important? Looking a little bit more specifically into emerging viruses. So we have new introductions, PED. We have things that were there for decades, but something changed in terms of PCV2. And populations was detected back in 1962, and we didn't start really seeing disease until 1990s, 1994. NGS certainly has opened the door into identifying some of these things that probably have been around for a very long time. And again, we don't really know where PRRS came from. So formal postulates for determining disease causation were first incorporated into an essay written by Henley all the way back in 1838 and subsequently revised by Koch in 1890. The inadequacies of these postulates in covering all of the potential permutations between pathogen and host become apparent within 10 years of their publication, but nonetheless remain a useful but limited framework for establishing infectious disease causality. Due to their limitations, others have set of criteria for determining disease causation that embodies disease ecology. So looking at this is the epidemiologic criteria for disease causality, except at least in the United States, we're just gonna jump over this one. We have pathology. So we can use diagnostics more than epi to really tell you if it's important within that animal, within that litter, and potentially within that herd. So look at it as a bit of a gas gauge where you're adding evidence as you fill your tank. Is it consistently detected by PCR using an accurate case definition at a high viral load? Is it detected on multiple sites? Is there repeated diagnoses? And is it detected in the absence or inconsistent detection of other known pathogens? Is there an absence of novel viruses? The difference between doing NGS on CNS fetuses versus feces and the validity of that in identifying important pathogens varies by specimen type. So CNS is really great when collected aseptically. Fetuses are really great because they're supposed to be aseptic. When you look at feces or fecal contamination of those other two sample types, it's a cluster. And then looking at lesion and in situ. Not all assays are created equal. Not all published photomicrographs are believable, and you really do need to start looking at controls. So immunohistochemistry versus ISH, these are all going to vary by the stage of the disease, the assay, the sensitivity of the specific assay, as well as the specificity. This is our initial PCV3-ish versus the cap is on top and the rep is on the bottom. You can subgrossly tell that one is significantly more sensitive than the other by the red staining that's there. So judging a manuscript, don't just read the title. Don't just read the abstract. It has become a pay-to-play. Crap gets through, not enough reviewers, and reviewers without knowledge are okaying these things. Do they have case definitions? Do they have the controls? Have they ruled out other differentials using the correct sample type and the validity of that assay? Are consistent lesions? Are they using an in situ? So in summary, select litters using a solid case definition. I would promote using 3 or more mummified fetuses and stillborns. Submit multiple fetuses per litter for histopath and molecular testing. Follow up with maybe differentials if you don't find what you think you're going to find. If you have sow samples, submit them when you have abortions. If mummies are present and you submit them, you should be able to find a virus if it's responsible, so PCR or next generation sequencing. Thank you all for your attention, BI, for the opportunity to present, and all the faculty and staff that help us go through all of these cases on a daily basis.
Fantastic. Thank you, Bailey. That was a roller coaster ride of pathology and great concepts. I'm sure we'll have lots of fantastic questions from the audience. I certainly was challenged and entertained at the same time. Thank you.